Hello, my name is Dr. John Kugler, and I'm here to do the 10-minute moment for jaundice. Now, the examination of jaundice is a great skill to have. It comes up in both the hospital setting as well as the clinic setting. Now, to get started, what you want to do is first identify a patient and then bring the learner to the bedside. So to do the 10-minute moment, you're going to bring your learner into the bedside with a patient, and you're going to have them perform the exam, and you're going to observe closely for an exam that's done well, and as well as areas for feedback that you can go over at the end. I'm going to show you the best exam that I can show you with our patient today. So when I get to the bedside with a learner, the first thing I want that learner to do is to confirm jaundice. Okay? Over the years, I've had many students who've mistaken pigmented sclera for a patient with jaundice. And so to confirm jaundice, what I first want to do is look into the patient's eyes, okay? And here our patient doesn't have any pigmented patches in their sclera. But if she did, what I'm going to do is just pull down on the lower lid and confirm that any pigmentation, which is usually to the left or right of the iris, is really not going to confuse me. I look at the bottom of the eye, and any jaundice should be really confluent. I should see the entire sclera is the same color. While I'm here, the other thing I can look for is the bottom here of the eyelid to look for anemia. Now, any patient who has such severe anemia from hemolysis that they get jaundice, they are going to be really, really pale. That should really just jump right out at me when I go ahead and look at their lower eyelid. And so I found this to be a very useful screening for even mild anemia, but certainly if I'm worried about why is this patient jaundiced, I should see really profound pallor. So now once I've confirmed this patient is jaundiced, and obviously our patient today actually isn't jaundiced, but if she were jaundiced, now I need to move on to try to understand better why is this patient jaundiced. So the next thing I'm going to do is really observation. And observation is key here. And one of the things that many learners forget to do is really fully expose the patient. Now to do this, I also want to maintain some modesty for my patient, maintain their comfort. Okay? But in this example, what I'm going to do is, okay, can I have you just kind of drop your gown to about your waist so I can observe your upper chest and back? Okay? Sure. When we're looking, the first thing we're going to observe for are spider angiomas. And these are very common in patients who have hepatocellular liver disease. And knowing where to look for them is really important. So we're going to leave our patient's mask on today, but I'm always going to observe the face and the cheeks. I'm going to observe the upper chest, the shoulders and the upper back, as well as the top part of the arms. These are the most common places we'll see spider angiomas. And I want to do a good job looking for that. I'm always going to come around to the back side of my patient, observe there, take a really good look at their skin. Okay? The next thing that we want to observe for is we're going to actually observe the abdomen. And so I'm going to make sure our patient is draped and comfortable so they don't get cold or feel exposed. And again, this is an important thing in the hospital, in the clinic, wherever you are, we want to make sure our patients feel comfortable. All right. And then do you mind just lifting your gown up to maybe just your bra line or so, just so we can see your abdomen? Perfect. Okay. So when observing the abdomen, I'm going to be looking for a couple things. So first of all, I'm going to look for dilated veins in the abdomen, okay? And so if I see any dilated veins, obviously we can look for things like a caput medusa, which is dilated veins right around the umbilicus. But even more commonly, I might just see dilated veins along the sides of the abdomen, and that can be a sign of hepatocellular disease. I'm also going to observe for bulging flanks, and obviously our patient does not have that today, but certainly if I saw bulging flanks, that could be a sign of ascites. So even before I get to touching or palpating the patient, I can already get a few clues as to how likely hepatocellular disease might be. The next thing I'm going to do is observe the palm. And to do this, I'm just going to borrow a hand here, and I'm going to use this hand just so we can see it easier. And I'm going to have you hold out your palm, and I love doing this with my learners. I hold out my palm, I hold out my patient's palm, and I say, who's got palmar erythema? And certainly most of them kind of point at my palm and they say, Dr. Kugler, your hand's really red, right? And that has a lot to do with my pale skin and my underlying physiology. But this is not palmar erythema, okay? When we look at a patient, we're trying to assess for palmar erythema, what I really want to see is I want to see islands of redness, right? So I'm really looking for islands of redness over the thenar and hypothenar eminence, as well as over the MCP. Those are the areas where I should really be looking for islands of redness. But importantly, the center of the palm is quite pale. And so that's a real good example of palmar erythema, whereas I have just a diffusely red palm, which isn't really important for anything other than maybe pale skin. So there's a few things we want to palpate for on the abdomen. So we want to assess both the liver size as well as the spleen size, and then we're going to check for something called Cavossier's sign. So what I'm looking for here is, can I actually feel the gallbladder? That's going to be the Cavossier's sign. And so obviously we know right here at the costal margin is going to be where the gallbladder kind of sits. It sort of sits right here. In a typical sign here, what I'm looking for is the gallbladder distended? It should be smooth and mostly non-tender. Now again, if you push hard enough on anyone, they're going to start complaining. So I'm just going to be very gentle here. I'm not trying to hurt you, but I'm just going to palpate and I'm going to see, can I feel a distended gallbladder? And I apologize, my hands are a little chilly.
It's okay.
Okay, and so again, the patient shouldn't be yelling out. Okay, this should be a non-tender gallbladder. If the patient yells out, they're in lots of pain, that actually is really changing my differential diagnosis. Maybe this patient has cholecystitis, maybe even cholangitis, right? But just purely obstructive jaundice often will give us a palpable and distended gallbladder, which I could palpate here, but wouldn't have significant pain. Next I want to see, is the liver enlarged? Now, to assess for an enlarged liver, I really need to be cautious because the liver, well, normally sits kind of right at the costal margin, maybe 1 or 2 centimeters below the costal margin, but can get quite large in certain diseases. So I really want to be careful that I don't miss an edge. Now, over the years, I've observed different learners who've tried to feel the edge of the liver and they feel like they've found it. And what they're often feeling is not the liver, but they'll feel a step off from the rectus abdominis, right? And if someone has very well developed abdominal muscles, they can push and they feel kind of a step off and they say, hey, I found something. So what you may want to remind them is, again, the rectus abdominis runs in this vertical pattern here. You're actually feeling for the liver to be more in a horizontal pattern. So again, if they're feeling their step off this way, you say, no, you got to correct it and feel kind of this way. Now when I look for the liver, I'm actually going to start down here and I'm just going to press gently, okay? And then I'm just going to have the patient breathe normally, okay? And I'm feeling, do I feel a little step off? Okay, and I'm just going to keep getting closer to the costal margin. And then once I'm at the costal margin, I will apply a little bit more pressure. As the patient breathes out, I kind of push in, and I'm doing this gently but firmly. I'm going to do one more feel right here. Great. Now, if I feel the liver below the costal margin, then I'm actually going to percuss to see if I can figure out the dimensions of the liver. Now in this case, I actually don't feel your liver edge, which is neither good nor bad. Certainly if I feel a liver edge below the costal margin, that could be abnormal, but I am going to percuss the span to see if it actually is. And I am going to just do a quick demonstration here. Normally if I don't feel a liver edge, I don't always percuss. But in this case, we're going to go ahead and do it just for demonstration. Now, it is a little harder with female patients who have breasts where you can sometimes not be able to percuss the upper edge of the liver, okay? Basically, in most patients, the upper edge, the upper border of the liver is right at the breast margin. And so as I'm percussing up, it's really hard to actually percuss through breast tissue, so you may not be able to percuss the upper border of the liver, but you can presume it sort of ends right there. So I'm just going to be very gentle here, and again, we're going to percuss here. Okay, we can hear that's nice and hollow. Still nice and hollow. And now we get nice dullness here. So I've found the lower border of the liver, and I'm just going to have you pull your gun up just a little bit more here, all right? And then we're just going to keep going, and we see nice and dull, and then now we're at the lower border of the breast. We're not going to actually percuss onto the breast, but what we can see here is in the mid-clavicular line, we have a fairly normal liver span. Now, if I was concerned, we'd actually pull out a ruler and measure this. It needs to be less than 13 centimeters. If it's more than 13 centimeters, I would be concerned that the patient may have an enlarged liver, and I would need to take further steps there. Next, we're going to examine for the spleen. Now, the spleen is another one, just like the liver. You really want to be careful that you get farther enough away because the spleen can get quite large. If I'm worried about an enlarged spleen, I want to start sufficiently away. And a massively enlarged spleen will either cross into the pelvis or actually across the midline. That's how we define a massively enlarged spleen. So I'm always going to presume maybe my patient has a massively enlarged spleen. I'm going to start over here, okay, and I'm going to be very gentle. And I'll spend just a time here with gentle pressure, have the patient take a breath, and I'll just feel, do I feel the spleen kind of brush my fingertips? Now I'm going to get all the way up to the costal margin, just like we did for the liver. And the last thing I'll do, so I don't feel a spleen tip right there, which is pretty common. In adult patients, it's actually uncommon to be able to feel a tip of the spleen. But to increase my probability just a bit, you're just going to feel me push here. And this is not something every learner needs to do, but it is a technique that I like. And I'll put my hand behind your back, and I'm just going to push up a little bit and see if I can actually push the spleen into my fingers. Okay? And that can be another way just to assess, is the spleen a little bit enlarged? But to be perfectly honest, if I can only feel the spleen tip by doing that, it's probably a fairly normal sized spleen. I've just managed to make sure I could feel it. You will find in some patients who have significant ascites, certainly if there's a lot of ascites, they can have an enlarged spleen. You may not be able to feel the edge because you'd have to push so hard through the ascites that they would be in too much pain. And so just know that your exam may be a little bit limited in terms of assessing the spleen when there's significant ascites there. If it's just a little ascites, you may actually have a pretty easy time finding the spleen. So it's really going to depend on the patient. Now, obviously our patient today doesn't have any obvious signs of ascites. We don't see bulging flanks, but I do want to go over how to assess for ascites. The two main techniques that I was taught were shifting dullness, as well as checking for a fluid wave. When we look at the test characteristics, the fluid wave does have slightly better test characteristics, so I'm going to show you that today. So I'm going to actually need your help to do this. And this is one of the classic ways that a lot of learners forget, is if you just tap on the side, especially patients who have a lot of abdominal adiposity, the wave can be transmitted from one side to the other through the adipose tissue of the abdomen. So in order to mitigate that, what I'm going to have you do is just kind of place the side of your hand across your belly. Yeah, just like that. In fact, you can even do two hands. You kind of make a little thing there. And the idea is that my patient is now going to block that transmission of any wave through the subcutaneous tissues. And I'm going to put one hand here just to feel, and then I'm just going to kind of tap over on this side and see, can I create a wave that's transmitted? And while I'm shaking my patient a little bit, I'm not feeling anything on the other side. And so that would be a negative fluid wave sign. And I feel pretty good that we don't have any ascites there. The last thing that we want to check for is we want to go ahead and look for peripheral edema. And so this can actually be a really helpful sign. It raises your probability of finding ascites. Now, this is another one that sounds really easy, but I've had some learners struggle with this over the years. If you have a patient who's got long-standing edema in their legs, this can be even patients who just have problems with, venous insufficiency, sometimes their legs can actually get pretty tender. And I've seen over the years a lot of learners say, let me check for edema, and they really come in with some force, and that can be quite uncomfortable with your patient. You can certainly lose some trust pretty quickly on top of just causing this discomfort. So what I like to do is just come over, and I'm really gentle, okay? And so I'm just going to place my thumb here, and I'm just going to hold it there for a few minutes. So while I'm here, maybe I'm checking pulses as well. Maybe I'm asking the patient some questions, okay? But after leaving my thumb here for maybe 30 seconds, sometimes even as long as a minute, I can just kind of rub my thumb back and forth. Now you can remind your learners, and I'll always check the other side as well, remind your learners, the more they do this, they'll start to feel the edema as soon as they touch the skin. So the last thing that we should go over is if you have a patient who is male, you do want to assess for gynecomastia. So one of the signs of liver disease in male patients is you can get a redistribution of the pubic hair, as well as gynecomastia in some of those patients. And so again, if you have a male patient, I would make sure that you also palpate over the pectoralis and feel for any breast tissue that shouldn't be there. This can be a sensitive topic for your patient, but certainly asking if they've noticed any changes. There are some patients who've had gynecomastia since puberty, so this may not be new for them, but certainly inquiring about it a little bit in a sensitive way can be quite helpful. The last thing we want to cover is just make sure that all of you know what to exactly look for with your learners. Where do they usually have trouble with this exam? And so number one is not exposing the patient sufficiently, not taking a good look at the upper chest, upper back, and shoulders to look for those spiderangiomas, taking a good look at the face. Some of them can be quite large and prominent, no one would miss them, but some of them can be quite small, and you really need to take a good look and take a few seconds at least to observe. Other things that they struggle with sometimes is when you get to the abdomen, not noticing the dilated veins that are there. They struggle sometimes with not starting sufficiently far away from the costal margin, and they risk missing organ enlargement. Some of them forget to assess at all for a distended gallbladder, and that can be really important. And then finally, the thing that the students struggle with the most is actually checking for ascites. And so making sure that you involve the patient by having them kind of block that wave through the subcu tissues can be really, really helpful. And then again, having them when they check, if they do decide to check for shifting dullness, though we do recommend fluid wave as our #1 way of checking for this, but if they do check for shifting dullness, have them percuss and then leave their finger there. Don't move it. Have the patient move while your finger stays in the same place. And that's a really nice way that you don't have to draw on the patient, leave your fingers right there. It makes the whole exam just go much quicker. Well, thank you all for listening to me go through the 10-minute moment for jaundice. I hope that all of you find this useful and that you can put this to use with your learners. Thank you.